So, welcome back, dear all. This is a special kind of module which is known as the recall series, and what we intend is to go through the previous year question paper or the recent most question papers, so that actually it has got different purpose, that is to sensitize you regarding which are the areas from which the questions are primarily asked. That is one. Secondly, you can go through these question papers and see what is your level actually, that is how much you know, that idea should be there for you, which will help you to improve further also. And there are certain areas, if I go through the last question paper and if you ask me how was the question paper, that is not that relevant, because it is not about how I felt about the questions, it is about how you feel about when you go through these questions. How do you feel about that is more important. And personally, I feel that there are certain areas which from which there are more kind of questions. For example, ILD, connective tissue disease associated ILD, or it can be occupational lung diseases, and such kind of areas there were more questions, and some which is related to infections. But there are certain areas which are left untouched also. Not much questions about obstructive sleep apnea, and there is no much significant or relevant questions regarding bronchiectasis. But the point is that this pattern can vary next time. For the next INI, for the next NEET, there may be more questions from these areas which were left untouched in the last exam. So if the questions are not supposed to repeat in the same way also, if it was like that, it would have been much easier. Both our job and your job would have been much easier. And I am very much happy and proud that this year, this question paper, it was very well done by our students, and we have got excellent results. That is something which I am very much happy about. Now let us go to the questions. And all the questions will not be covered. All those questions which are which we have got a clear-cut idea, as well as which were recollected by our own students, where the options are also we could recollect. These are the questions that we are about to discuss. So what is the most useful biopsy in dermatomyositis? Polymyositis means what is the site of biopsy? So skin, muscle, fat and transbronchial lung biopsy, and the answer is muscle biopsy. There is no point in going for a lung biopsy if the clinical, radiological as well as the serological features are suggestive of dermatomyositis. So these kind of things are very important, and so basically it belongs to what is known as an idiopathic inflammatory myopathy, or IIM. So some of the inflammatory myositis is associated with interstitial lung disease. That is why we are interested in this particular rheumatological condition. So basically dermatomyositis, as the name indicates, it has got skin manifestation as well as muscle features also. The skin I will explain in the coming up slide, and the muscle features is that it is characterized by proximal muscle weakness, which is slowly progressive also. So the patient will be proximal muscle weakness. Okay, so the patient, if you ask, they will complain about difficulty in sitting, standing up from sitting position or from squatting position, inability to lift something which is having some weight. Then there can be weakness in the neck muscles. These kind of things are there. So usually it affects both the limbs also. And there are particular type of variant which is otherwise known as amyopathic variant. What is the term indicates? Amyopathic, there is no significant muscle weakness, but there are some skin features, and then there can be features of interstitial lung disease also. So this is a variant of idiopathic inflammatory myositis. So skin rash and muscle weakness. So what does this picture depict? This can be a spotter for you. So in quiz competitions, etc. So these are the metacarpophalangeal as well as interphalangeal joint, the dorsal aspect of the hand showing erythematous as well as violaceous lesions are there. So that is known as Gottron's papules. Gottron's papules. Similarly, over the face, you can see erythematous lesions over the face, and that is known as, you might have learned already, that is heliotrope rash. Both of them are very characteristic sign in dermatomyositis. So how do you proceed? So basically it's a clinical evaluation is important. For example, the skin manifestations that we have discussed, then the muscle features, whether the patient is having muscle weakness, then you can go for a muscle biopsy if it is indicated. And of course you have to evaluate for respiratory symptoms, whether the patient is having chronic cough or a progressive exertional dyspnea. In such conditions, HRCT test is also indicated. That is how you evaluate a patient with this kind of disease, and of course it includes a MDT or a multidisciplinary discussion from the pulmonologist and also from the rheumatologist. So anti-Jo1 antibody, again a question which is related to dermatomyositis. It is seen in dermatomyositis, and it is a kind of amino acid transfer RNA synthetase antibody. So that is why it is known as a anti-synthetase syndrome. It is the most common myositis specific autoantibody. So there are myositis specific as well as myositis associated autoantibodies are there, and one among them is anti-Jo antibody, and that is characterized by, as I told you earlier, there can be skin manifestation, there can be arthritis, there can be mechanics hand, Raynaud's phenomenon, sclerodactyly, and to our interest there can be interstitial lung disease also, and among them NSIP pattern is very commonly seen also. MDFI is very significant because the ILD which is associated with this kind of myopathy or myositis has got a rapidly progressive course. So rapidly progressive ILD, dermatomyositis, and cutaneous involvement, and here it is a kind of amyopathic inflammatory myositis. So there is no significant muscle weakness there. The skin manifestations and lung manifestations are more predominant. MDA, melanoma differentiation associated gene, is the full form. You need not remember the full form. Anti-MDF5 is a kind of myositis where the ILD is very much progressive and difficult to manage. That is the point that you should remember. So the management is, of course, it is basically an autoimmune condition. So anti-inflammatory medicines like steroid, and most of the time they may require immunosuppressant also. Okay, what is the most common pulmonary manifestation in SLE? The most common pulmonary manifestations include pleuritis. So the patient can complain of pleuritic pain. SLE patient complaining of pleuritic chest pain is not that uncommon. It can be present in more than 40% of patients with SLE. And so what are the lung manifestations in SLE? So what is this? This is the classical malar rash, as you might have already learned in the MBBS time. Malar rash, discoid rash, etc. Photosensitivity. These are all the manifestations of SLE. What are the other features other than the rash, photosensitivity? What all other organ involvement? There can be arthritis, there can be glomerulonephritis, very important, and it can be progressive, it may require dialysis. Such kind of things are there. Cytopenia, there can be thrombocytopenia, there can be anemia, and there can be neurologic involvement in SLE also. So it's a multi-system inflammatory autoimmune condition. So our interest is what is the lung involvement in SLE. So there can be features of acute presentation like lupus pneumonitis, where the patient can present with acute onset of dyspnea. It may mimic a community acute pneumonia also. So the patient will have hypoxia. They may require ventilatory support even. So another thing is pulmonary embolism. SLE patients are prone for developing venous thromboembolism, whether it could be DVT, whether it could be pulmonary embolism also. There can be lupus pleuritis, as I already told you. The patient can complain of pain, and there can be diffuse alveolar hemorrhage also, where the patient can have hemoptysis, fall in hemoglobin level, and there can be hypoxia also. There are some other conditions which can have a insidious onset or a subacute to chronic course. For example, interstitial lung disease is there. Thromboembolism can persist for long time, resulting in pulmonary artery hypertension or chronic thromboembolic pulmonary hypertension. There can be pleural effusion, and there can be shrinking lung syndrome in SLE also. So pleural effusion is definitely a significant one among this, because it is a sign of serositis. So serositis is a diagnostic criteria for SLE also, and if there is serositis, there can be pleural involvement or pleural effusion. Regarding Kaplan syndrome, which is wrong, so here we have to pick out the wrong statement. It is associated with rheumatoid arthritis, that you all know. It is related to inorganic dust exposure. Of course, it is an occupationally associated disease also. Histological features include necrosis, inflammation, and there can be inhaled coal dust or silica particles if you get a biopsy from the affected lung. But the nodules are predominantly seen in the periphery, not in the perihilar area. So it is a peripheral nodule, not a central predominance. So what is Kaplan syndrome? It is a pneumoconiosis associated with rheumatoid arthritis. So rheumatoid arthritis plus occupational lung exposure, resulting in multiple nodules within the lung. That is the classical presentation, or the original case report of Kaplan syndrome was like that. And the nodules are usually bilateral, And as I told you earlier, it is more having a peripheral distribution, and some of them can cavitate also because of the necrosis. It can cavitate, sometimes it can disappear, sometimes it can remain stable, sometimes it can progress also. There is no specific treatment for that, but the clinically important point is that it is a differential diagnosis of secondaries. The nodules in rheumatoid may look like a secondary, so that is the importance of getting a biopsy there. Xylophilaris disease, this was a age-old question and very direct question also. I have got this question in one of the quiz competition also. So because it has got a straightforward answer, that is why it is very easy to make a question regarding Xylophilaris disease. There is no confusion regarding the option, nothing like that. So if you know the answer, you can pick it up. Nitrogen dioxide is the right answer, and don't confuse with N2O. It is nitrogen dioxide, NO2. So what is Xylophilaris disease? It is a practice which is more predominant in the European countries, where the farmers there will store their collected materials, whether it is cereals or some sort of their own agricultural products, in large containers like this. And what happens is that this will undergo fermentation in course of time, and that will release what? Nitrate, and finally that will emit nitrogen dioxide also. From the nitrate in the corn or other cereals, it will emit nitrogen dioxide because of the fermentation process. And if it is more than 50 parts per million, it can affect the lung also. In what way does it affect? It can cause pulmonary edema like kind of thing. It can cause a cough. It can cause exertional dyspnea. Sudden desaturation can be there. So it can cause pulmonary edema, and bronchiolitis obliterans is another thing which is due to exposure to nitrogen dioxide. It is usually reversible also. Okay. So just mug it up. Most common pulmonary manifestation, rheumatoid arthritis. Now they are asking about rheumatoid arthritis, and PH is there, pleural effusion is there, bronchiolitis, ILD is there. As for the textbook reference, it is interstitial lung disease. So what are the lung manifestation? Rheumatoid arthritis, it's a usual question in your short note exam for your theory, DNB or MT. It is a usual ward question, ward round question. It's a usual exam question, as well as it has appeared in the NEET SS exam also. So ILD, from the literature, it is interstitial lung disease. So what are the different manifestation? What I already told one, that is Kaplan syndrome. There can be interstitial lung disease, and which is more common, UIP pattern is more common compared to that of other CTD ILD, where it is NSIP which is more common. So remember this point also. Then it can be bronchiolitis. Different types of bronchiolitis has been described in rheumatoid arthritis, follicular bronchiolitis, obliterative bronchiolitis, different kinds are there. Then there can be rheumatoid effusion, that is also characteristic. I have detailed that in the module on effusion. The characteristic features are low sugar, etc., low pH, very characteristic of rheumatoid. That is also an important and interesting area for question. And there can be cricoarytenoid involvement. So upper airway involvement is very classical and characteristic of rheumatoid arthritis. Sometimes cricoarytenoiditis itself can cause some sort of voice change, some sort of dry cough, etc. to the patient. And pulmonary artery hypertension is not that common in patients with rheumatoid, but still it can occur. But when compared to that of scleroderma, etc., the prevalence of PAH is much less in rheumatoid arthritis. Okay. So parenchymal involvement, pleural involvement, cricoarytenoid, and bronchiectasis is also described in patients with rheumatoid nodule, Kaplan, and pulmonary hypertension. Organizing pneumonia can also be seen in patients with rheumatoid. And other thing is that those patients who are on treatment like methotrexate, leflunomide, etc., that can sometimes induce and drug-induced interstitial lung disease also, even though the latest report says that the incidence is much less than that was previously anticipated. So adjunctive treatment in lupus pneumonitis, which among the following is not used? Diuretic, antibiotic, plasmapheresis, rituximab, all these are used as a adjunctive treatment for lupus pneumonitis, along with the ventilatory support, oxygen support, etc. As I told you earlier, lupus pneumonitis can have an acute presentation. It can mimic a pneumonia-like presentation. It may require oxygen and other immunomodulatory treatment like rituximab, plasmapheresis, steroids, immunosuppressants, etc. But there is no bronchospasm as such, so bronchodilators are not indicated in lupus pneumonitis. So again, it is an uncommon SLE manifestation, acute interstitial pneumonia-like presentation, where the patient can have hypoxia also. So the differential diagnosis includes infection, pulmonary edema, diffuse alveolar hemorrhage, etc. So the management, as I already told you, does not include bronchodilator. Distinctive feature of shrinking lung syndrome. Again, as I told you, this is a manifestation of SLE. It's not that common again. So the shrinking lung syndrome is basically due to the diaphragmatic involvement. So the characteristic is that the patient will have, it's a rare complication of SLE again, it will have only 1% prevalence in SLE patients. What is the exact pathogenesis? It is still unknown. It should be suspected in a patient who is having dyspnea on exertion with or without dry cough, and if you get a clinical examination, most of the time it will be normal. Chest x-ray will show bilaterally elevated hemidiaphragm also. Okay, the pleuritic pain can be there or it may not be there also. So what happens is that it is characterized by an elevated diaphragm in chest x-ray. The lung volume will definitely be reduced. FVC will be reduced if you take a PFT. Why? Because the diaphragm is very much high. So it will compromise the lung expansion. So FVC will be low. Alveolar arterial oxygen gradient and ventilation perfusion mismatch is not there. Why? Because whatever lung is there, it is oxygenating normally. There is no pathology at the alveolar level. That is why these two things are remaining normal in a patient with a shrinking lung syndrome. So chest x-ray, there can be unilateral or bilateral elevated diaphragm. PFT, the lung volume will be reduced. Most common pulmonary manifestation dermatomyositis is non-specific interstitial pneumonia, as I already told you. Most of the connective tissue, this kind of inflammatory myositis conditions, the predominant pattern is NSIP. Okay. So IIM, ILD, idiopathic inflammatory myopathy. So I am not going into the details once again. So understand that it can have some sort of skin manifestation. The muscle weakness is very characteristic. Usually it is a proximal weakness. It usually progress. There can be patients with exertional dyspnea, cough, which could be manifestation of underlying interstitial lung disease also. And it is a very important extra-articular manifestation, and it has got a prognostic significance also in patients with idiopathic inflammatory myositis, because it indicates a poor prognosis. The presence of ILD in inflammatory myopathy is a poor prognosis. So which trial is not associated with idiopathic pulmonary fibrosis? Straightforward question. If you know, if you have gone through it, it will be very easy to pick it up. Ascent trial and capacity trial, what are they? The role of pirfenidone in IPF. Pirfenidone in IPF. These trials came into effect even before I did my MD, so that much old trial. And InJourney trial is actually nintedanib plus pirfenidone in IPF. Again, it is a trial which is related to IPF. InBuild trial. What is InBuild trial? It is a landmark trial which is done in progressive fibrosing interstitial lung disease or progressive pulmonary fibrosis. This is the recent terminology for that. Initially it was PFILD, now it is progressive pulmonary fibrosis. So the subjects were all those patients who is having a progressive ILD other than IPF. In those patients, nintedanib reduced the progression rate of that particular ILD. So that is the role of nintedanib in progressive pulmonary fibrosis. So it is not related to IPF. So worst prognostic factor for IPF. Again, this has been discussed in the module on IPF. Many questions we have discussed. This is one. And young age of onset, extent of honeycombing, severity of cough, FEV1. So of course it is even by using logic you can pick up the answer that extent of honeycombing is always a bad prognosis in IPF. So these are some of the prognostic factors: age more than 70, the delay in diagnosis, of course, the degree of dyspnea, comorbidities, low DLCO, low SpO2, low 6-minute walk test, extent of honeycombing, pulmonary hypertension, decline in all these factors over the period of time. All these are bad prognosis, and I already have discussed regarding the gap index in the module on IPF. It is the full short form of gender, age, and physiological variables. So GAP, gap index. So what are the physiological variables which is included in the prognostication? FVC and DLCO. So we can get an MCQ next time from the gap index itself. They can give FEV1 and ask you which of the following is not included. So FVC is there, DLCO is there, but FEV1 is not there. Static compliance is decreased in. This is a topic which is related to the lung physiology, or you can tell it could be related to the basic first year topic in MD or DNB. So it is decreased in ARDS. So what is compliance? Compliance is the measure of distensibility of the lung. Compliance is the measure of distensibility of the lung. That is, if you give a particular pressure to the lung, how much the lung is expanding just like a balloon. So what do you mean by a good lung? A lung which expands very well to a minimum pressure. That is a good lung because it expands very well. So compliance is change in volume by change in the pressure. That is actually the transpulmonary pressure. Okay. So there are two types of compliance, that is a static compliance as well as the dynamic compliance. So static compliance is measured when there is no airflow through the airway or the conducting system, and dynamic compliance is measured whenever there is an airflow. Understand that any pathology that is affecting the alveolar level, will affect static compliance as well as dynamic compliance. Okay, and the pathology which is affecting the conducting system, whether it is an endotracheal tube or whether it is the major airway, if there is the pathology alone without involving the alveolar level, it will affect the airflow and hence it will affect the dynamic compliance, but the static compliance will be the same. So bronchospasm, ET kinking, airway obstruction are all related to the airway passage, and hence the static compliance will not be affected there. Okay, I hope you have understood the concept. So this graph also you should remember, this is the x-axis, the transpulmonary pressure, and this is the y-axis which is showing the change in volume. So what is compliance? How much change in volume of the lungs with respect to change in pressure. And this is a new question, and this you should be very much aware about it, because this is something which I expect to be repeated in the coming exams also. So that is a new diagnostic modality of tuberculosis. Not tuberculosis disease, actually a diagnostic modality for TB infection, that is known as CYTB. And so which of the following is correct? More than 10 mm is diagnostic, and which is the correct answer? More than 5 mm of induration is the cutoff. Just like Mando, one vial can be used up to 20 days after opening. It can be I will tell you that if we will not produce, repeat the test 2 inches from the original site. So that is also correct. Less specific than Mando, that is also correct. One vial can be used up to 28 days after opening. So the wrong statement is box or B. So what is CYTB? It's an intradermal test. So what is Mando? Again, it is an intradermal test. So in that way, it is similar to Mando. So it is a recently developed test, and so basically what happens is that we are using almost the same method, that is injecting the antigens which is specific to Mycobacterium tuberculosis in the forearm, few inches below the elbow, and we are in what route? Intradermal route, and see a induration is produced or not. So the induration, if it is not produced, we can repeat the test somewhat around 2 inches from the initial site, or we can do it on the opposite side. That was one option. And if the vial is around 1 ml in volume, and each injection will be having 0.1 ml, so one vial can be used for how many patients? 10 patients. Okay, and you will read the report after 48 to 72 hours. And just like the Mando, what will you measure? You will measure the induration. What is the diameter of the induration by using a scale and pen. And if it is more than 5 mm, it's suggestive of what? It is suggestive of, just like Mando, infection with tuberculosis. It is not diagnostic of TB disease. So what is the advantage of this? It is very specific for tuberculosis. The problem with the Mando is that those who have got an NTM infection, those who have taken BCG recently, will be having a false positive Mando. But here the antigen is very much specific for Mycobacterium tuberculosis. So this thing will not cause a false positive result in CYTB. Correct? So what is the each volume of each injection is 0.1 ml. This vial is 1 ml. Okay. So this is how it is measured. We have already discussed that, and please go through this guideline, National Tuberculosis Elimination Program on CYTB skin test. 1 ml vial, each injection 0.1 ml. All those important information have been discussed in that. You should download it and go through it. Okay. So a patient with INH monoresistance develops quinolone resistance. So it's a question about INH mono or poly drug resistant regime. Which of the following to be added next? So linezolid, cycloserine, clofazimine, ethionamide. The answer is linezolid. So INH drug resistant TB regime. What is that regime? The particular TB bacilli is having resistant to INH. So it is very easy to remember the regime. Instead of HRZD, it becomes, you replace INH with levofloxacin. Then it becomes the ANH mono drug resistant regime. Now the problem or the question is related to the fact that the patient is intolerant or he has got some sort of resistance to levofloxacin also. So that has to be replaced by linezolid, and this has to be continued for 6 to 9 months also. So if levofloxacin or pyrazinamide cannot be used, in that case replace it with linezolid. And the order of preference is that first you will take from linezolid and then from clofazimine, and if that is also not possible, then try cycloserine. That is the order of selection of drugs. Just remember that, that's all. A smoker with following CT features, histological analysis of surgical lung biopsy shows this finding. What's the most likely possibility? So this is the best thing that we could have recollected from those who have written the exam. I don't know whether this CT picture or this particular histology was there or not, but this I have framed it in such a way that it would be useful for you. I don't know whether this was the correct frame of that question which was asked in the exam. So a smoker with the what do you see in the CT? It's a bilateral diffuse ground glassing and some sort of interlobular and intralobular septal thickening is also there. Predominant area of ground glassing is in the bilateral lower lobe. This is what you have got from the CT. So basically it should have been an interstitial lung disease. He is a smoker also, and here I don't know whether you will be able to appreciate it or not. It is actually a carbon-laden macrophage. That is what they have highlighted. So carbon-laden macrophage is a characteristic feature of DIP. What is DIP? Desquamative interstitial pneumonia. So desquamative interstitial pneumonia, characteristic ILD, which is very commonly seen in smoker. Other kind of ILD which is seen in smoker is respiratory bronchiolitis associated interstitial lung disease. Here the patient will have dyspnea on exhalation and cough. If you take a CT, as I already told you, diffuse ground glassing is the usual pattern because it indicates an inflammation at the level of alveoli. And if you take a FOB BAL, as I told you earlier, carbon-laden macrophages is very characteristic. Young female with this we have discussed in the module extensively. Young female with a prior history of recurrent pneumothorax, that itself will give you some clue. And CT is shown below. What is the likely possibility? Again, the picture I have added. So what do you see in the CT? Two things you got. One is it's a young age in the reproductive age group. She has got recurrent pneumothorax also. What might be the reason for pneumothorax? That is what you see in the CT. That is bilateral cystic lung disease is actually there. Bilateral diffuse cystic involvement of both the upper lobe, and the cysts are of different size also. So one of the cysts might have ruptured and resulting in pneumothorax. So being a young female with recurrent pneumothorax, the most likely possibility is lymphangioliomyomatosis. LCH more commonly seen in male smokers. This is not a picture of bullous lung disease or emphysema. The CT picture is not suggestive. So lymphangioliomyomatosis, I am not going into the detail because there is a dedicated module on that. There is a high yield module on ILD where I have gone through the LAM and LCH, such kind of things very extensively. So it's a cystic ILD that you have to remember. It is more commonly seen in young female. The usual symptom is recurrent pneumothorax. That is what we are more commonly or we are more interested with. And the skin manifestations are hypomelanotic macule like this, hypomelanotic, hypopigmentation. There can be this kind of lesions in and around the skin. This is a periangular fibroma, shagreen patch. This is a shagreen patch, and these are angiofibroma, very classical of lymphangioliomyomatosis. Some of them can be associated with the neurofibromatosis, and the patient can even have seizure. So pneumothorax with a seizure, always think in terms of tuberous sclerosis associated conditions also. So what is this? Another CT, again bilateral diffuse cyst you can see, and one of the cysts might have ruptured and resulting in a right-sided pneumothorax also. So what do you see in the CT abdomen? This is nothing but an angiomyolipoma. That is a classical feature of LAM. So lymphangioliomyomatosis. So angiomyolipoma is a renal tumorous-like condition which can lead to spontaneous bleeding also. So Bitt-Hogg-Duke syndrome is again a question that we have discussed in the module on cystic ILD. Bitt-Hogg-Duke syndrome is caused by mutation of, it's a direct straightforward question. It's basically folliculin gene mutation, and the answer is autosomal dominant condition. Again, it is characterized by skin fibrofolliculomas. Again, it is a cystic ILD with a skin manifestation of fibrofolliculomas, and the characteristic association is renal carcinoma. Renal cancer is a classical association of Bed-Hogg-Dube syndrome, and it can also have cyst in the lung. And here the cysts are not that much extensive as that of LAM. Usually it involves around less than 10% of the lung parenchyma, and the in between lung is very classically normal also. You can see normal lung here, normal lung here. Some of the cysts can rupture and result in a pneumothorax also. Okay, so how will you make a diagnosis? One classical thing is that the CT, you can see multiple cyst, which is more commonly seen in the lower zone. Predominant cyst is there. The in between lung is normal. There can be history of pneumothorax, but the recurrence is not that much high as that of LCH or LAM. The renal tumors are very classical. Usually it can be bilateral also. So bilateral renal tumor is very important, and there can be a primary relative who is having a similar disease, or you can do a genetic test and see whether there is a folliculin gene mutation or not, and you can see the classical dermatological finding of a fibrofolliculoma, or you can get a skin biopsy also. So that is how you make a diagnosis. Renal tumor is associated with, again, the question that we have discussed. The answer is Bed-Hogg-Dube syndrome, and don't confuse it with the angiomyolipoma. It is not a renal carcinoma. Here the renal malignancy is associated with the Bed-Hogg-Dube syndrome. High altitude pulmonary edema, drugs that can be, so always give a more importance to cystic ILD. We are seeing repeated questions almost every year with respect to cystic ILD. Please refer to the module also. High altitude pulmonary edema, that drugs that can be made use of all include all except. So this kind of none of these, all of which of the following are wrong, which of the following is the correct one, all except, these kind of adjectives you should be very careful. Don't get confused and don't jump into the right answer. So here you should identify all the drugs that can be used and which one cannot be used. That is the right question. That is the right answer is theophylline. It does not have any role in acute high altitude pulmonary edema. Nifedipine, dexamethasone, acetazolamide, all are recommended, and acetazolamide is the one which we usually give for prophylaxis also. Okay, so high altitude pulmonary edema is a one condition which is seen in patients who ascend to higher mountains or like that. So basically it includes acute mountain sickness which may present with the headache. Then you have got the high altitude pulmonary edema, high altitude cerebral edema also. Okay, so the patient will have cough, there can be dyspnea, there can be difficult to ascend, there can be even desaturation, and so the patient may require oxygen support, positive airway pressure support, like that. So what does the acetazolamide do? So basically it depends upon many factors. One is the host factors, how healthy is the patient is, whether he had prior history of high altitude pulmonary edema, then there is high chance of recurrence. The height, the altitude to which he is going, higher the altitude, greater is the chance of this kind of things. The rate of ascent, you are supposed, if you are going to a Mount Everest base camp trek, you are not allowed to, you will have a limitation to particular ascent for 24 hours, then you have to take rest, and then only next day you have to go further. So you have to limit the rate of ascent there. And other comorbid conditions also. All these influence the developmental chance of high altitude pulmonary edema. Acetazolamide, what does it actually do is that it will result in a bicarbonate diuresis. So it will help in excretion of bicarbonate through urine. Okay, so what happens? The bicarbonate level is going down. So what will happen? There will be a metabolic acidosis. There will be metabolic acidosis because the base is getting lost. There will be metabolic acidosis. So what will be the respiratory compensation to prevent further acidosis? There will be hyperventilation. There the ventilation level will increase so as to remove the carbon dioxide, so as to limit the acidosis. That is why the ventilation is improving when you take acetazolamide, and that will improve the ventilation to your lung. That is the idea behind acetazolamide. Patient with sudden onset of dyspnea on USG evaluation, which of the following finding is suggestive of pneumothorax? So here you have to pick up the right answer. This also we have discussed extensively in the module on two modules. One module is on pneumothorax, other module is on USG in pulmonary practice. In both the modules we have discussed it. So absent common tail sign is a sign, which is suggestive of pneumothorax. Lung sliding will be absent in pneumothorax. B lines will not be seen in pneumothorax. Shred sign is a sign of segmental consolidation not related with pneumothorax. So the right answer is A. So UC pneumothorax is a very useful thing because it can be done in bedside, it can be repeated, it can be more sensitive than that of a chest x-ray. It can identify a very minimal pneumothorax with the help of the lung signs that we have discussed earlier. And the normal lung, these are the signs, the lung sliding, B lines, A lines, etc. So which is this sign? This is the reverberation artifact, that is the A line, and you can see the movement of the parietal pleura with respect to the visceral pleura, sorry, the movement of the visceral pleura with respect to the non-moving parietal pleura, that is producing what sign? The lung sliding sign, which is a sign of normal lung. Again, the B lines, these are otherwise known as comet tail artifact. These are also reflections which are seen in normal lung, and it can be accentuated in which condition? In lung flooding or pulmonary edema, there can be more B lines. What is this sign? This is the sign in normal lung where this will look like the shore and this will look like the sea, and that is known as the seashore sign. That will be absent in pneumothorax. That will be replaced by barcode sign, also known as what? Stratosphere sign in pneumothorax. And very specific sign is that point where the pneumothorax ends and there is the normal lung here. You have got a pneumothorax up to this area, and from here onwards there is the normal lung. So this point you can see the lung sliding on one side and absence of lung sliding on the other side. There will be seashore on one side and stratosphere or barcode on the opposite side. That particular point is the lung point, very specific for pneumothorax. So which of the following? So that is the radiological sign of pneumothorax. So ultrasonic signs in pneumothorax is a very popular area for MCQ exams. So please refer to the respective modules. Which among the following is given as IV? A question which is regarding the monoclonal antibodies that we have discussed in the GINA guideline module. This we have discussed. So the one which is given as IV is racilizumab. So the omalizumab is an anti-IgE antibody which is used in severe asthma. Not only in severe asthma but also in severe urticaria, chronic rhinosinusitis with nasal polyps, all those conditions it can be used. It is given as subcutaneous injections. Benralizumab is an interleukin 5 receptor antibody which is again given as subcutaneous in eosinophil driven asthma. Mepolizumab, again it is an interleukin 5 antibody, subcutaneous. Racilizumab is an interleukin 5 antibody which is given as IV. So which among the following is acting against the receptor? That can be the question next time. So it is the benralizumab which acts against the receptor. So that's about that. This is another question which we have discussed in the module on empyema, which is the correct statement. Empyema, the patients will definitely be having, it's a infection related condition, or it's a complication of a pneumonia kind of thing. So there is a very easy to identify that this will be having a high protein. Of course, it is a neutrophilic, and empyema, all empyema will have a low pH also. So what are the different stages of empyema? As I have already discussed, I am not going into too much detail. It is characterized by exudative phase, the fibrinopurulent phase, as well as the organized phase which happens at the last endpoint. Okay. So in all the stages it will be a proteinaceous fluid, and most of the time it will be having a high neutrophil count. The counts will be very much high, and the sugar and pH, because there may be bacteria which may be identified in the culture or which may not be identified, but most of the time there can be microorganisms which will consume the sugars for their metabolism, and so the sugar will be usually low. In the initial stage it can be normal, and when it progresses to the fibrinopurulent stage or begins the phase of empyema, the sugar will be low, and since the bacteria metabolizes that and results in the formation of lactic acid, the pH will be low and the LDH will also be very much high. So which is any fluid parameter to determine the necessity of intercostal drainage? This is not a question which is I have discussed in the module. I just want to stress this out, because if you aspirate the fluid and if you get a frank pus, then go for chest drain. There is no question about that, because wherever there is a pus collection, you have to take it out. If there is a culture or gram stain positivity for the microbiological test that we have done for the particular fluid sample, again if the bacteria is there, you have to put the tube and drain it out. In addition to that, pleural fluid pH is a very important factor which will help you to make a decision to put an ICD or not, to drain it or not. If the pH is less than 7.2, better to put a chest drain. And if pH measurement is not feasible, you can go for sugar as well as LDH. So if the pH is in between, see the LDH. If it is very high, consider intercostal drainage, especially if it is a large effusion, when the patient is having fever, when the glucose level is low. If there is septations on ultrasound, it indicates a complicated effusion. There it will be better to put a chest drain, and if it is necessary, use altiplase or streptokinase and do adhesiolysis with medical thoracoscopy. Pleural contrast enhancement also suggests of ongoing infections as well as inflammation, so that is another factor which may help you to take a decision on chest drainage. So that is empyema. Please refer to the module, which is true regarding primary spontaneous pneumothorax first episode management in a patient who is breathless and pneumothorax is less than 2 cm on chest X-ray. Again, we have discussed this on the module on pneumothorax with reference to the particular guideline from British Thoracic Society regarding the management of pneumothorax. So it is a primary spontaneous pneumothorax. In that case, if the patient is breathless, the needle aspiration is as effective as intercostal drainage. So the reference is a BTS guideline. Please go through that. Please go through the module discussion also. So spontaneous pneumothorax, if the size is more than 2 cm or breathless. So here the patient was breathless. So put a needle and try to aspirate it and see the patient is improving. If the patient is not breathless, you have taken an X-ray, for some other reason you are finding a pneumothorax and that is less than 2 cm, keep under observation only. No need for a needle aspiration. So this is the rest of the management of secondary spontaneous pneumothorax. You are advised to refer to the module. Which among the following is an interleukin 4 antibody? So Bendrali, Mepoli and O'Malley we have discussed, and the interleukin 4 antibody is a dupilumab. So is it just affecting the interleukin 4 alone or anything more? Yes, it's an interleukin 4 as well as it works against interleukin 13 also. There are some new reports coming for its potential use in COPD. It is well known to be having a good effect in those patients with severe asthma. So that is about dupilumab. Again, it is given as subcutaneous injection. So this is another question regarding dupilumab in COPD, and what is the indication or what is the role of dupilumab in COPD? So recurrent exacerbation with high eosinophil count is the one which may get benefited with the dupilumab. It requires more and more evidence anyway. Stable COPD, there is no requirement for dupilumab because it is costly, because it is an injection and the patient is stable. Why do you want to give him injections? Recurrent exacerbation with a neutrophil, no much role, or if there is a role, it has to be proven beyond doubt. Gold A stage, no role for monoclonal antibodies. So that is the dupilumab in COPD that is being mentioned in the recent gold guidelines also. So remember that 2 or more moderate exacerbation or at least 1 or more severe exacerbation. Despite severe exacerbation, if it is like that, 1 or more, despite LABA, LAMA plus ICS, and the eosinophil count is more than 300 per ml, then you may consider dupilumab in patients with COPD. That is the current indication for dupilumab. So ABPA patient not improving on steroid and antifungal, which is the agent having a promising data. This we have discussed on the module on ABPA. So please refer to that, and the agent having a promising data is omalizumab. Rituximab does not have a role in ABPA. Dupilumab and mepolizumab, not that much evidence is there. So this is the guideline which we have discussed, and we have gone it through the high yield module on ABPA also. This was a recent publication which was published in 2024, if I remember it right. Revised Disham ABPA Working Group Clinical Practice Guidelines for the Management of ABPA. Okay, so reverse halo sign is seen in mucormycosis, cryptogenic organizing pneumonia, invasive aspergillosis, COVID-19. So it's a sign which is described in all these conditions. The answer is all of the above. So what is reverse halo sign? So reverse halo sign is characterized by a central area of ground glassing which is surrounded by an area of consolidation. This is otherwise known as an atoll sign also. So inverse halo sign or atoll sign. very characteristically described in invasive pulmonary aspergillosis. It has been described in COVID-19, organizing pneumonia. This is another BOOP. This is another BOOP. Sorry, this is another atoll sign. This is another atoll sign. This is even described in tuberculosis and other kind of fungal infections. So remember that atoll sign or inverse halo sign. It's a non-specific sign. It need not be present in organizing pneumonia alone. It can be seen in fungal infections and other kind of malignancies, etc. So just remember the terminology: inverse halo sign or atoll sign. Fallen lung sign is which is false. Another radiological sign. It's seen in complete bronchial tear. I will go to the explanation first and we will come to the MCQ later. So what does this chest x-ray show? The left lung is normal. What do you see here? There is more black in color on the right side without any bronchovascular markings. You can see a collapsed lung border here. So what does this indicate? It is a pneumothorax. And what does this indicate? Here there is a tube also. I hope you have identified the ICD tube. So someone might have rightly identified the ICD, sorry, the pneumothorax, put the ICD inside it, but the lung is not expanding. Why? Because there is an ongoing air leak which is compressing the lung to the one particular side and it is getting collapsed. So a pneumothorax which is not improving with the ICD, always consider the possibility of a tracheal or bronchial tear. So this is the fallen lung sign, where the lung has fallen down to the dependent portion like this because of the compression from the persisting pneumothorax despite an ICD, because the air leak is that much high, because it is due to the presence of a complete bronchial tear. So the lung is not held up by the bronchus, it is just holding to the hilum just because of the vascular attachment. That is why it has fallen down to the dependent area. That is why the fallen lung sign, usually associated with the persistent pneumothorax. It is not seen in flail chest. It is associated with the bronchial tear. So 1, 2, 3 are correct. This thing is false. But it may be associated with the rib fractures also, because basically it is due to trauma. But the direct reason is a complete bronchial tear, not because of the rib fracture. It may be an associated condition. Young male for pre-employment screening, chest x-ray is given below. What is the radiological possibility? It's a straightforward question. We had I have seen only one case till date. That was during my MD time. And this x-ray, as you can see, shows multiple diffuse bilateral, very high density nodules is seen in the x-ray with a lower zone, mid zone predominance. And it's an young male also. Pre-employment screening means that the patient is not that much symptomatic. Somebody took an x-ray, have this finding. So what is the diagnosis? It is pulmonary alveolar microlithiasis. It is characterized by extensive bilateral dense deposition of calcium inside the alveoli. Not only along the alveoli, but along the interlobular septa also. So calcification in and around the alveoli, along the septa, along the fissures are characteristic of pulmonary alveolar microlithiasis. So basically that is an inherited condition, or it is a genetic condition where there is an abnormal metabolism of surfactant. Because the degraded surfactant, there will be excess phosphate. This phosphate is cleared out from the alveoli by a phosphate co-transporter gene. In those patients with the mutation in the phosphate transportation gene, the phosphate will get accumulated in the alveoli. That will combine with calcium, resulting in the formation of these kind of spherules, and that will get accumulated over and in and around the lungs, resulting in pulmonary alveolar microlithiasis. So the radiology will be very much horrible, but the patient will not have that much symptoms, but in course of time the disease will progress and he will develop dyspnea on exertion like that. So here also you can see the dense calcific spherules and calcified fissure as well as interlobular septa. So this is otherwise known as the two signs which are mentioned in with respect to pulmonary alveolar microlithiasis, that sandstorm appearance. It looks like a storm of sand, that much dense, and it is some area which is close to the subpleural area. The calcium deposition will be less when compared to the other area, so that will give a slight black appearance towards the periphery, towards the pleural site, and that is known as the black pleura sign. Black pleura sign. So remember the black pleura sign, very popular area for quiz competition questions as well as for SS exams. So black pleura sign, again it is a radiological sign of pulmonary alveolar microlithiasis, and there is no treatment, or there is no cure till date. So the management is mainly rehabilitation, supportive care, etc. So the next question is milky white ball is characteristic of what? So this is the image. I don't know whether they have given the image or not. For your understanding, I have kept that image. So the question was basically something like milky white ball, and these were the options, I think, and the answer is pulmonary alveolar proteinosis. So again, this was discussed in the module on pulmonary alveolar proteinosis. Remember two things with respect to pulmonary alveolar proteinosis. Three things actually. It's a condition which is related to abnormal surfactant metabolism. One thing. It can be congenital, it can be secondary, like that. The radiological characteristic is a crazy pavement pattern. That is another area from which the exam questions can come up, because crazy pavement means that there is areas of ground glassing and there are septal thickening like this also. This is the crazy pavement or interlock stones which is kept in like that, and this is compared to this kind of appearance. So this is the ground glassing. Along with that, there is septal thickening. That is known as crazy pavement pattern, and this is not specific for pulmonary alveolar proteinosis. This can be seen in pneumocystis carinii pneumonia, different kinds of viral infections, COVID. Even COVID can have crazy pavement. So this is the milky white ball which is characteristic of pulmonary alveolar proteinosis. So this can get sedimented also. So it is milky white. And this is positive for this is eosinophilic also if you examine it, and this will stain for PAS positive also. There can be foamy macrophage also. These are the features of this kind of ball in pulmonary alveolar proteinosis. So that much you have to remember. And now regarding the another question regarding ball, this was also discussed in the module on diffuse alveolar hemorrhage. So I have told the answer also. Sequential ball showing hemorrhagic fluid is a characteristic feature of diffuse alveolar hemorrhage. This is one of my own case where this is the ball which we take this is the first sample. You can see that it is much reddish in color, but the ball which is taken from the next sequential ball from the same area, it is getting more reddish or more bloodier than the first one. So that is a sign of diffuse alveolar hemorrhage, which indicates that the bleeding is ongoing at the alveolar level. So sequential ball showing hemorrhagic fluid is a characteristic of diffuse alveolar hemorrhage. Another one is that you can send the ball for cytological analysis, and that will show this. What stain is this? This is a Pearl's Prussian blue stain. PEARLS, Pearl's Prussian blue stain, which shows hemosiderin laden macrophage. Hemosiderin laden macrophage. Okay, because the alveolar macrophage will try to clear away the blood from the particular alveoli and keeping the iron in the form of hemosiderin getting deposited there. So that is how you see diffuse alveolar hemorrhage, hemosiderin laden macrophage, which is very characteristic finding. Angiomyolipoma is a feature of, we have already discussed, it is the right answer is lymphangioliomyomatosis. NAV has shown good results in which of the following condition? Type 2 respiratory failure with acidosis, non-cardiogenic pulmonary edema, asthma exacerbation, type 1 failure. These are less identified indications for non-invasive ventilation. The classical indication is type 2 respiratory failure with pH less than 7.35. So the right answer is answer A. Please refer to the module on NIV also. So this is the guideline that you should read when you get time. That is an official ERS ATS statement on NIV in acute respiratory failure. So type 2 failure with a PCO2 more than 45 with acidosis. Hypercarbia without acidosis is not an indication for NIV. Hypercarbia with acidosis less than 7.35 is a classical indication for NIV. Of course, NIV is used to facilitate weaning from mechanical ventilation. There is no recommendation till now for hypoxemic patients, but if the patient is very much having work of breathing, not willing for, or the family is not intending for invasive ventilation, such kind of conditions, of course, for hypoxemia, you can go for non-invasive ventilation. Due to uncertainty of evidence, unable to offer recommendation on use of NIV for acute respiratory failure due to asthma. This is the ATS statement. So for asthma, there is no much evidence of NIV if there is an asthma exacerbation. The other indications are, of course, which has been discussed in the module: obesity, hypoventilation syndrome, chest wall diseases, chest trauma with respiratory failure. Neuromuscular disease is a very important indication, especially for home and navy also. So this I have taken from the guideline which I have shown you earlier. So look at this: acute asthma exacerbation, the certainty of evidence is not that much there. And de novo respiratory failure, hypoxic respiratory failure, no much evidence. Pandemic viral illness means COVID and all, no much clinical data is there. That is why. Another question again, which is discussed on the module on NIV. NIV is contraindicated in vomiting, massive hemoptysis, facial trauma, but in patients having some sort of drowsiness, if it is due to hypercarbia and acidosis, definitely the patients will show excellent results. This is from our own experience also, because once you keep starting on NIV, by around 1 hour there will be an improvement in carbon dioxide. By around 2 to 3 hours there will be carbon dioxide washout, and so the patient's sensorium will also improve. And the most important thing is that it may obviate the, or it will avoid the necessity for a mechanical ventilation or an intubation also. So what are the contraindications? Hemodynamic instability, inability to fix the air interface, maybe due to multiple issues, due to the abnormal facial issues or facial trauma, severe GI symptoms like extensive bowel distension, inability to protect airway because the patient is very much drowsy due to some other reason, because maybe of CVA, IC bleed, like that. Massive hemoptysis, copious secretion. Why it is contraindicated? Because there is higher chance of aspiration. Undrained pneumothorax, it can go in for a tension pneumothorax. Post cardiac arrest. These are the usual contraindications for NIV. Most common symptom of pneumomediastinum, this I think they have taken directly from a statement in Fishman. So please refer to the textbook also. They have referred to the textbook and made out this question. Most common symptom of pneumomediastinum is chest pain as per the textbook, as well as with respect to different articles which I have referred also. Cough can be there, dyspnea can be there, some change in voice, nasal tone, all these things can be there. But the most common symptom is a chest pain, which is usually pleuritic. It can be pleuritic also. It is usually a central chest pain which can radiate to the back and also to the neck. So what is pneumomediastinum? It is the presence of air in the mediastinum. Where else do you see air here? Is, of course, there is subcutaneous emphysema also. It may be associated with a pneumothorax. Sometimes it can happen without a pneumothorax also. So that is about pneumomediastinum. So understand that chest pain can be a presenting symptom of pneumomediastinum. So this is an important question, and this I will mark a star because there is a high chance of this question getting repeated in the next exam and even for the coming years also, because this is a new molecule. That is the importance, and this is mentioned in gold also. So ensifentrine is a new molecule which has been evaluated in COPD. Basically, it is a molecule with a dual action actually. So double role is there. So it has got a phosphodiesterase 3 inhibitor and a phosphodiesterase 4 inhibiting action. Phosphodiesterase 3 inhibiting action helps to increase the level of cyclic GMP. Thereby, it has got a bronchodilatory action. Phosphodiesterase 4, you might have already learned that roflumilast, classical example. The same mechanism is there for ensifentrine, and thereby it acts as an anti-inflammatory agent. It is available in the nebulized form. 3 mg twice daily is the non-dosage, and it is approved by FDA. So the wrong statement is fourth statement. So this is the classical trial. Please go through the trial when you get the time. When you get time, enhanced trial. Ensifentrine, a novel phosphodiesterase 3 and 4 inhibitor for the treatment of chronic obstructive pulmonary disease. So it is approved by FDA. Remember that. Then this journal has been published in American Journal of Respiratory and Critical Care Medicine. I think it was in 2024, I think. So it is a dual action molecule. Cold 2025 also there is a mentioning on ensifentrine that raises the importance of this particular molecule. Again, what all things I have mentioned is there in the gold guideline also. Is currently available only in United States, I think. So ICS is not given in COPD when. Again, this is covered in the gold module discussion on COPD. So eosinophil, if it is more than 300, more than 2 or more exacerbations per year, concomitant asthma, you are justified in giving an inhaled corticosteroids along with the bronchodilators. If the eosinophil is less than 100, the efficiency or the utility of giving an ICS is limited. You are not supposed to give it. So again, this I have taken from the GOLD 2025 guideline. Please refer to it, figure 3.21. So factors to consider when initiating ICS treatment. So what are the factors which strongly favor the ICS in COPD? As I already told you, the patient is having recurrent exacerbations despite LABA/LAMA, and he is having a eosinophil count more than 300, and history of concomitant asthma strongly favors the use. And against the use is that the history of tuberculosis, history of recurrent pneumonia, and the eosinophil is less than 100. If it is 100 to 300, or if the patient is having one moderate exacerbation, then also you are justified in giving ICS. So that is what is known as what therapy? Triple therapy. What is triple therapy? ICS, long-acting beta-2 agonist, long-acting muscarinic antagonist. That is the standard of treatment in patients with recurrent exacerbations in COPD having a high eosinophil count. Now this is another question which is related to vasculitis. Patient is having epistaxis, breathing difficulty, and cavitating nodule. Which one can be positive? So epistaxis and cavitating nodule, some sort of vasculitis reference, of course the answer is vaginous granulomatosis or granulomatosis with polyangiitis. That is the correct terminology, where C ANCA is usually positive. So why it produces epistaxis? Because it produces necrotizing granulomatous lesions in the nose. That is why it produces epistaxis. Similarly, because of the necrosis which is involving the lung parenchyma, it can cause cavitating nodules. The nodules can be bilateral, it can be multiple. There is no particular zonal predilection. Some of the nodules can cavitate also. So these are the points which with respect to the vaginous nodules, and some can have a thick walled cavity also. So more than 50% can cavitate. So the differentials become tuberculosis, fungal infections, cavitating secondaries, etc. But these patients will have a renal involvement most of the time, and on further evaluation there can be C ANCA positivity, and there can be biopsy which may show a necrotizing granuloma. Such kind of things are there. So this is another question which is related to GPA. A patient is having epistaxis, nasal involvement, diagnosed already. They have given the diagnosis as GPA, but there is no systemic involvement. What is the correct treatment to induce remission? So if there is no systemic involvement, you are justified in treating with prednisolone and methotrexate. But if there is lung involvement, renal involvement, etc., definitely you require steroid, some sort of immunosuppressants like MMF, and depending on the case, you may select plasmapheresis, IVIG, pulse steroid, etc., depending upon the severity. So nasal limited vaginous granulomatosis, you can treat with prednisolone and methotrexate. This is another statement question which is based on eosinophilic granulomatosis with polyangiitis. This we have discussed in the module on eosinophilic lung disease. There is a module on that. No gender predisposition. It's a disease which does not have any gender predisposition. That is true statement. Prodromal phase precedes the vasculitic phase by 3 to 6 years. That is correct. Necrotizing granuloma of the upper airway are unusual in EGPA. Cavitatory lesions are more frequent in EGPA. Actually, it is more frequent in GPA. It is less frequent in eosinophilic granulomatosis with polyangiitis. So previously it was known as the Churg-Strauss syndrome. Cavitatory lesions are more common in vaginous than in Churg-Strauss. So I am not going into the detail because we have covered that in the module. Remember that there are three phases. One is prodromal phase for EGPA, where the patients will have some sort of allergic symptoms, rhinitis, sinusitis, etc. Then there will be an eosinophilic phase where the patients will have significant eosinophilia with a severe asthma. Most of the patient will have severe asthma at some point of time, followed by the vasculitic phase where the patient will have some sort of vasculitic features like joint pain, skin manifestations, etc. So the classical features include eosinophilia, very high, the Ig levels can be high, there can be sinus involvement, there can be transient pulmonary infiltrates, there can be mononeuritis, there can be arthritis, All these phenomenon can be there for eosinophilic granulomatosis with polyangiitis, and most of the patient will have severe asthma, difficult to control asthma at some point of time. Which among the following is a large vessel vasculitis? It's a straightforward question. The answer is Takayasu arthritis. Even though it does not have significant pulmonary manifestation, so the vasculitis they are classifying into two: large vessel vasculitis. The classical example is giant cell arthritis and Takayasu arthritis. Polyarthritis nodosa and Kawasaki disease, medium vessel vasculitis. Again, the pulmonary manifestations are very limited. The rest of the vasculitis are usually small vessel, ANCA-associated vasculitis, Henoch-Schonlein purpura, microscopic polyangiitis. These kind of things are small vessel vasculitis. Another question that we have discussed on the genetics in lung cancer module. Genetics in lung cancer module. EML4 ALK mutation is targeted by which of the following agent? Gefitinib, osimertinib are which targeting agent? EGFR inhibitors. Imatinib, we don't have much involvement in CA lung. So basically, gefitinib and osimertinib are EGFR inhibitors. The crizotinib is EML4 ALK mutation inhibitor. So one word regarding osimertinib, it's a third generation EGFR inhibitor. And the advantage is that it will have more specificity for the mutant EGFR. So the skin rashes, the diarrhea or other GI symptoms with the gefitinib and erlotinib are less with respect to osimertinib. It has got better CNS penetration, less. It will help to prevent the CNS metastasis more. So that is about osimertinib, and it is active against T790M mutation also. So it is active against exon 19, exon 21 and T790M mutation on exon 20 also. Other mutations on exon 20 other than T790M, this osimertinib will not work. So remember about osimertinib, that is another area that you may get a question. Please refer to the module also. EML4 ALK, it's seen around less than 10% of adenocarcinoma. It is actually a fusion mutation. Young non-smoker female adenocarcinoma, more or less the same population pattern where EGFR positivity is also more noted. So again, females and non-smokers have a higher chance of having these kind of mutations. But if this mutation is present, EGFR, RAS mutations will not be present because they are mutually exclusive. So which drug is used there? If the patient is having mutation, it is crizotinib, which was the profile trial. You need not remember it. So it will inhibit the ATP binding site of anaplastic lymphoma kinase or ALK. In addition to ALK, it will inhibit the MET as well as ROS mutation also. The side effect 250 mg BD is the dose, and so side effect you should remember: visual disturbance and diarrhea. Diarrhea is common for almost all EGFR inhibitors also, but visual disturbance is characteristic side effect of crizotinib. So you can remember that when you cry there will be some sort of visual disturbance, right? So crizotinib, visual disturbance. Second generation ALK inhibitors include selectinib, alectinib, brigatinib, and third generation includes lorlatinib. Okay. Which among the following is so please refer to the module. The targeted therapy in CA lung is a very important area for question. So which of the following is a slow growing NTM? We have covered that in the module on NTM. Please go and refer to the module on NTM. I have covered the textbook as well as the ATS guideline on that particular topic. It will help you to save your time, that is for sure. So the answer is Mycobacterium avium, Chelonae, Apsis and Photium. They are all slow growers. The other one is not a slow grower. NTM is otherwise known as a ubiquitous or environmental mycobacteria because it is present everywhere. Usually it is not pathogenic unless the patient is immunocompromised. So this is the run-neon classification of NTM. It's predominantly of historical importance. And so the group 4 is rapid grower, abscesses, Chelonae, Photium. The others, group 1, group 2, group 3 are classified based on the ability to produce pigments on exposure to light. So you should remember the other terminologies: Kensaci, Marinum, photochromogens. Those produce pigment in the dark as well as the light, Gordonea and Scrophulaceum. Those agents which cannot produce pigments, they are Mycobacterium avium as well as Haemophilum. So how will you make a diagnosis of NTM? The clinical symptoms includes constitutional symptoms, persistence of cough, fever, etc. Radiology, there can be bronchiectasis, there can be nodules, there can be cavitations. More or less it will be similar to that of a tuberculosis itself. But if you have sputum cultures, more than or equal to 2 sputum cultures should be positive. one is not enough, but if you take a BAL, one sample is good enough. Or you should get a biopsy where you can grow NTM in a culture, or more than one sputum culture which is positive for NTM if you get a biopsy which is suggestive of granuloma or acid fast bacilli. So this is how you make a diagnosis of NTM according to ATS guideline. Please refer to the management also in the module, and wish you all good luck.